Hello everyone and welcome to Make Medical Easy. I am Prabuddha Goswami and I am a pre-final year student at JIMS Pajpaj. And today we'll be talking about gallbladder stones and the process of formation of these gallbladder stones, which is called as cholelithiasis. Moving on to the first slide, we can see that there are a picture of two of our most favorite fast foods, right? One is the KFC meal and the other is chicken biryani. Now, my friends, if I ask you a very common question, as to can you tell me which nutrient is present in both these meals in a very high quantity? Of course, you are correct if you have uttered fats. And of course, I'll also be telling you that both these meals also do contain a considerable amount of protein in them. There, correct. However, the proportion of fat in them is considerably much higher. Okay, so what happens is that when we consume meals like these, which are very lip smacking to the mouth and to the taste buds, however, meals like these, become a little bit difficult for our stomachs and our intestines to absorb. Okay, so as the food goes, as these fat-rich food goes into our stomach, it gets a little bit difficult for the stomach to absorb them, right? So in here steps our friend, in steps our friend, the gallbladder. Okay, so what is the function of the gallbladder? Moving on to the next slide, we can see that the gallbladder stores a liquid in them, in it, I'm sorry, which is called as the bile. Okay, now the bile is made in the liver and then stored and concentrated in the gallbladder. Now, what does this bile do? This bile helps in the digestion and absorption of the fat. Okay, so once these fat-rich meal comes into our stomach, the gallbladder is activated and the bile is released, and this bile emulsifies the fat and hence aids in its absorption and of course digestion and excretion. Okay, and bile essentially consists of bile salts and phospholipids, which form the major chunk of bile, whereas the minor components include the cholesterol and the bile pigments like bilirubin. Moving on to the next slide, we can see, so what are the predisposing factors, which uh, make a person vulnerable to develop these gallstones? They are obesity, excess of female sex hormones like estrogens, or the use of oral contraceptive pills. We have, of course, increasing age, pregnancy, and drugs, certain drugs like octreotide and clofebrate. Of course, high fat diet, like I told you, my friends, and of course, the killer or the or the harbinger of all maladies, diabetes mellitus. Moving on to the next slide, we can see what are the types of gallstones. Okay, so essentially, we have three major types of gallstones. The first type are the cholesterol gallstones or the yellow stones, which are composed mostly of 80% of more of or more of cholesterol, and they are the most commonest gallstones that we can find in day-to-day practice. The other are the pigment stones, which may be black stones or brown stones, and they contain less than 20% cholesterol. Okay, however, their bilirubin content is very high. And on the other hand, thirdly, we have the mixed stones, which contain both the cholesterols and which are composed of both cholesterol and these pigments. Okay, and of course other components like calcium, bile salts, etc. Moving on to the next slide, we can see a very beautiful picture of cholesterol gallstones or the yellow gallstones. Okay, so the formation of these yellow or cholesterol gallstones require three mandatory factors. What are they? Number one, we have lithogenic bile. Okay, and this lithogenicity in the bile is caused by three main factors. One is a supersaturation of bile. Secondly, we have the deficiency of bile acid. And thirdly, we have the deficiency of lecithin. Second of all, there's a process called nucleation, which is aggravated in our bodies due to infections and mucinous glycoprotein formation. And lastly, there is stasis of the gallbladder, or which contains the retention of this bile within the gallbladder itself. So when the food is coming in, the gallbladder is unable to secrete the biles. So of course, this will lead to formation of cholesterol gallstones. And like I told you, the yellow stones are composed mainly of cholesterol monohydrate crystals. Okay. Moving on to the seventh slide, there's, we can see a diagrammatic representation of the etiopathogenesis behind the formation of these gallstones. Okay, we can see that there's supersaturation of cholesterol. And what do we mean by supersaturation of cholesterol or the supersaturation of bile? It refers to when the solubilizing capacity of bile, okay, is like, what do you call it, the cholesterol concentration within the bile, is far exceeding its solubilizing capacity. So what is happening as a result, there are chunks or nuclei of cholesterol forming within the bile itself. Okay, this causes the formation of vesicles, again, which can be unilamellar or multilamellar. And then finally, we can there's always lithiasis or microstone formation. And when these microstones aggregate, or congregate together, they form the huge gallstones. Next, we move on to the pigmented gallstones. As we can see, there are black stones and there are brown stones, like I told you before. So let's study about the black stones first. So these black stones are composed mainly of the insoluble bilirubin pigments, which are mainly a polymer of calcium phosphate and calcium bicarbonate, right? They are of course hard and they are radiopaque. And what are the risk factors which predispose to the formation of these bile stones or these excess black stones? They are chronic hemolytic conditions. For example, if there is any persistent or congenital hemolytic condition in our body, for example, of course, hemophilia, then there is any hereditary conditions like hereditary spherocytosis, or there are specific systemic syndromes like the Gilbert syndrome. Next, we have the brown stones. Now, the brown stones are composed mainly of three components. They are calcium complexes, obviously, and they're calcium bilirubinate, calcium palmitate, and calcium stearate. Yeah. And what is the most common location of these brown stones? They are most commonly located within the common bile duct. And of course, they are more common in areas which are endemic to worm infestations. And worms like Ascariasis, or Onchocerca, these worm infestations predispose an individual more to the formation of these brown stones. Okay. Now, my friends, it is very important to keep in mind that this last point about the and the cases of the formation of the brown stones being higher in the areas where there is this significant worm infestations. Now, why is this the case? Moving on to the next slide, we can see the pathogenesis of the brown stones in here. So what is happening, like you can see in the X-ray as well, there is a very distinct picture of an ascaris, which is being lodged into the gallbladder wall. Okay. So what is happening after a person is being attacked or is having an ascaris infestation? Some of these worms, will enter into the gallbladder, and what will happen, they'll die, of course, because the interiors of the gallbladder is not a very hospitable environment, right? So what will happen, these worms will die in the common bile duct, and as a result of the detritus of this worm which is present in the common bile duct, there is infection by gram-negative organisms, organisms like E. coli and Klebsiella. And these organisms produce a very characteristic enzyme which is called as beta glucuronidase. Okay, and what does this beta glucuronidase do? This beta glucuronidase converts the conjugated bilirubin into unconjugated bilirubin, and thus once there's a high amount of unconjugated bilirubin in our body, there is the unfortunate formation of brown gallbladder stones. Okay. Moving on to the next slide, we can see the difference between the pathogenesis of both the black stones and the brown stones, right? So black stones are formed in sterile bile, whereas the brown stones are formed in infected intrahepatic or extrahepatic ducts. So, of course, because these ducts are infested by our, dear friends, the worms, right? And black stones are due to the formation of increased production of unconjugated bilirubin, whereas brown stones are mainly caused due to the bacterial hydrolysis of conjugated to unconjugated bilirubin, like I told you in the previous slide. And mainly it consists of pigments, pigments polymer, of calcium phosphate and calcium carbonate. And whereas the brown stones contain calcium bilirubinate and calcium soaps of fatty acids and cholesterol. Now, what happens when there is stasis? There is increased precipitation of the pigments, and these components, which ultimately causes the formation of stones in both the black stones and the brown stones. Okay, so we have the pathogenesis. Moving on to the next slide, we have a case presentation as to how will essentially a patient of who's suffering from acute cholecystitis present to you in your hospital. So a patient is 57 years old, who's a woman most importantly, and is admitted to the emergency with right upper quadrant pain and tenderness with a positive Murphy's sign. Okay, so we did USG, and there was a large and a thin-walled gallbladder in the woman. So obviously, as you can see, this is a case of acute cholecystitis. Okay. So what other characteristic clinical features, that is signs and symptoms, which this woman will present with? So obviously, as you can see, as I told you in the case as well, it is a 57-year-old lady, right? So you'll always remember that cholelithiasis is more common in females. Okay, there are fat fertile 40 and flatulent females, as you can obviously remember the mnemonic: fat, fertile, 40 and flatulent. Okay, 10% of gallstones are radiopaque, they're asymptomatic in a few cases, and they mostly present with symptoms of biliary colic. Okay, hence the positive Murphy sign. That is, as you can see, as I also read to you in the question also, there's right hypochondriac and epigastric pain which radiates to the chest, back and shoulder, which is obviously severe and may present in an off to on and off manner, and is precipitated by having a fatty meal, like again our biryani and our KFC meal, right? And of course, like all anorexic patients, they'll be vomiting, fever, and of course increased white blood cells, okay, in the blood. Okay, so on palpation, as we have said, there's positive Murphy sign. So what essentially is this Murphy sign? So the patient is first asked to exhale. Okay, and this is obviously a part of palpation where the examiner places his hand below the costal margin on the right side at the mid-clavicular line. Okay, and then the patient is asked to inspire. So as the patient of acute cholecystitis inspires, okay, the patient winces in pain, and there's a catch, quote unquote, catch in his breath. Okay, and why is this happening? This is obviously happening because the gallbladder is inflamed, right? It is enlarged, and when we inspire, the gallbladder descends, and it is hitting the fingers of the examiner and thereby causing immense pain to the unfortunate patient. Okay, moving on to the next slide. So how do we assess our patient? Of course, there are certain investigations like abdominal ultrasound, ultrasonography, radionuclide, imaging, and cholecystography, so on and so forth. Okay. However, what is the investigation of choice in these patients? Always remember that it is ultrasound. Okay. And what do we find on ultrasound? We find that if indeed a gallbladder stone is suspected, okay, there may be 10 to 15% gallbladder stones which are calcified sufficiently, which indeed make them visible to the X-ray or the ultrasound. Okay, moving on to the next slide, we can see that there's a very characteristic picture of gallstones that you can see on ultrasound. Okay, and there are typical acoustic shadows which are indicative of small foci of also multiple stones which are present within the gallbladder. Okay, now ultrasound was our investigation of choice, right? And then what is the gold standard for investigation of cholecystitis? Okay, that is something called as an HIDA or a Heda scan. HIDA stands for hepatobiliary immunodiacetic acid scan. Okay, this is a very important point which you can include in your answers and your MCQs. Okay, and what is the diagnostic criteria for acute cholecystitis in a Heda scan is obviously the non-visualization of the gallbladder. If we move on to the next slide, we can see there is interpretation of the Heda scan, where of course, in case of an acute cholecystitic patient, you can see that the gallbladder is not visible, whereas there's a distinct shadow of a common bile duct and the small bowel. Okay. And then moving on to the management of the patient, how can we manage this patient? Obviously, we can give him, nutritional and supportive therapy. Then we can go into pharmacologic or medical therapy. Then there's non-surgical removal, surgical management, and of course, post-operative care or nursing management. Okay. So what is the pharmacotherapy? In the next slide, we can see the pharmacotherapy is targeted towards dissolving or dissoluting these gallstones, and that is done by UDCA, that is ursodeoxycholic acid. Okay, of course, if the patient has a functioning gallbladder, we can give him him or her a UDCA. And of course, we also have to keep in mind that the stone must be that the stones must be of of diameters less than 10 millimeter. only then will our UDCA be effective. And of course, if there are multiple stones or if the size of the stone exceeds 10 millimeter, we'll go into surgical resection. And the surgery of choice in this patient is of course laparoscopic cholecystectomy, which is ideal. And of course, if a patient is unfit, for laparoscopic surgery, we can go, for open cholecystectomy via the right subcostal, incision, which is also called as Coccus incision. As you can see very clearly with a beautiful image which has been, given to you in the presentation, and thereby, resect these gallbladder stones out. Okay, so my friends, thank you for your patient hearing. I have tried to keep this lecture as crisp and concise as possible, of course, as time is of paramount importance in our field, and I hope it was of some value. And of course, we must always remember, that we should always ideally aim towards, living a healthy lifestyle where we must think positive, we must eat better, and exercise as often as possible, and feel good, and this cycle should continue. Of course, this is indeed a very difficult task to keep up in our medical field, but we must put our best foot forward, right? With that, thank you. I'll take your leave for today.